everyone. I'm excited to be here today and chat about health equity. We're going to keep it nice and intimate. This is not like a lecture. It's not going to be uptight. We're just going to have a conversation and go through some things. Next slide.
Do we have somebody clicking slides?
Yeah, but this isn't my slide.
Yeah.
The first one was that if you could click that Canva link and follow that. If you go back and you highlight on the right that Canva link is not a PowerPoint, and you highlight that, if you could screen share that slideshow, it says www.canva.com at the bottom of that. The hyperlink, yes, where you are right now.
I'm having some trouble with that. I'm sorry.
It's okay. So I guess we really are going to have a little conversation. I'm just going to pull up my little Canvas. So it's going to be tiny. So we'll just talk. So a little bit about me. My name is DeRouen. I'm a family physician who's also board certified in family medicine, lifestyle medicine, and diversity medicine. I am very passionate about making healthcare more equitable, and I have been working for the past 4 or 5 years in telehealth. So we're just going to talk about how to attack that with the community. And the big topics for discussion are the 6 Ds. So we're going to talk about diving deeply into digital health a little bit, defining disparities, diving into distrust, dissecting how inequity can kill, talking a little bit about the determinants, which everyone has heard about mostly, and how to do the work. So there's a lot of confusion sometimes with the different terminology that people use in the telehealth space. So you hear digital health, which is in the title, telemedicine, telehealth, and you can kind of get confused over, are they the same thing? Are they different? How are they different? So just a little background, telehealth is kind of like the all-encompassing body of delivering care using technology. So it can include medical care, it can include teledental, mental health, there are therapy and all of those kinds of things, as well as like physical therapy and all of the things you can kind of do online or with a mobile device to provide some healthcare. Whereas telemedicine is a little more antiquated in the name, but we use it a lot. And it's more specific into providing medical care in those modalities. So it can be the things that you guys are seeing pop up where people are going on Teledoc or using Keeps for hair growth and all of those kinds of things where they use their mobile device to check in and get a care for a service. Then there is other modalities where we use telehealth for remote monitoring. For instance, if a patient is in a rural area and they need a neurologist, they can kind of scream in on the rounds while they're there, and you can check the monitoring and the devices for cardiac units into other hospitals, so you can have one provider cover greater services using technology. And then digital health kind of encompasses all of that, and it's kind of interchangeable with the telehealth component. So if I had slides that were working, it would say that it would have a whole bunch of pictures of a whole bunch of different companies. So we all know that telehealth has been out there for a while, but not really used at the point it's been used at now until the pandemic started. So there were probably a couple hundred telemedicine companies coming up over the past decade or so. But in 2020, now there are thousands of companies popping up every day, trying to find their niche and trying to figure out where it's going. And the market is kind of getting saturated. So my next slide had a little video. So I'm gonna just talk it through you. How many of you guys have seen the Jetsons before? Okay, so some people, it's old school. My mom used to like watch it with me. So it's like a futuristic cartoon for those who haven't seen it, where they have like hoverboards and the cars are moving, and it was in the 60s, but they were imagining what it would be like now, and we haven't gotten there yet. But in one of the episodes, one of the sons, Elroy, he was sick. So mom was like, let me call the doctor. So she turns on the TV and the doctor's like hologram, like comes in and he's like, all right, stick out your tongue. And he does like an exam virtually. So it was the first time like virtual visits were shown on TV in 1962. So we know that telemedicine isn't new, it's just growing and evolving. So then I had a long, boring timeline that kind of talked about telemedicine over time. And I won't give you each and every point, but what we're going to say is it started in the 1940s, actually, in Pennsylvania, where they shared the first electronic like radiograph record via like fax. And then in the 1960s, telemedicine, like as we know it, like mental health started in the 1960s, where they actually had video visits using a television and they were providing psychiatric services. And it's grown over time to come with, of course, like the digital age. So NASA had tests in the 60s that were talking about doing remote medical monitoring. And then in the 90s, the internet came. So of course, we're looking at all these ways to digitize. So from there in 93, they had the founding of the American Telemedicine Association. And that's the big governing body for you guys who may not be familiar. And they actually just had a conference this past weekend. And from there, we just talked about expansion, how to bring it into like getting reimbursement for medical treatment. And of course, in 2020, we had COVID-19, which brought the boom, and we were trying to reimagine and redefine how we provided and received healthcare, because there's limited access in terms of patients being able to get into spaces safely and not catching the virus, as well as protecting the providers as well. And then also with the nuances of people who actually had COVID, not exposing those who may have been coming in for blood pressure or something else. So it definitely boomed, and that's when a lot of the companies started to spark. So a lot of people have questions, especially in the healthcare realm, about like, can telemedicine like actually help? Is it here to stay? Like, why are we still using it if our numbers are going down and those types of things? And the answer is yes. So telemedicine has provided access to rural areas. It's provided underserved care for people who may not have insurance or who cannot pay for things. It's cleared up some waiting rooms for people who may have come in for like, I don't know, they wanted to come in, they know how their blood pressure has been and it's been doing well, and they have monitors at home and they've been recording their things and it's stable, they just want to refill or stuff like that. So it's definitely been an asset in conjunction with in-person care that can also like can never be replaced. If you're having a heart attack, you can't call a doctor on the phone and be like, hey, can you give me a cabbage? So it's definitely a time and a place for it and an adjunct for in-person care. But as we all know, we have to acknowledge the elephant in the room, that healthcare is not equal for everyone. So we know that there are systemic doctrines and things put in place to create barriers from people from certain demographics. So with all of that, we bring up healthcare disparities. So, and it's okay if you just say no if you don't want to participate or if you don't know. Does anybody know what a healthcare disparity is? Yes.
Different groups have different issues because, like, where we live in Houston, there's areas that don't have any transportation, and they're usually poor Black areas, and they have a hard time getting to the doctor. There's elderly who were close in; they have a problem getting in. I'm a retired RN.
Yeah.
So, there's people who are immune compromised, can't go in because there's sick people in the office, so they can't go in.
Absolutely. You're absolutely right. So there are these barriers to healthcare that are kind of unfair, because if everyone was given the same standards there would not be these barriers to provide getting the adequate care. So as you mentioned, there are many different groups. It can be racially segregated, it can be by age bias, it can be by disability. There are so many different ways that people are experiencing healthcare inequities. And I really wish you guys could see this slide because it kind of gives like a little model of the different groups that have been experiencing healthcare inequity. So some of the ones that I mentioned, as well as different ones like people where they live, like rural areas have healthcare inequities, people who have different sexual orientations, people who have different learning capabilities may have some disabilities and even have some issues with using things like telemedicine if you're not approaching and trying to meet them at their literacy levels. So there was a study by the Kaiser Family Foundation that basically it was a survey, and it kind of looked into why people aren't going to the doctor by different demographics. So it's saying that 60% of Black people trust doctors to do what's right most of the time, while 80% of Caucasian people do. And then in another question, it said 56% of Black people say that they mostly trust hospitals, whereas 70% of white people. So there's definitely a difference in the trust levels. So we can't really know like where we're going unless we know where we've been. So I really had this big plan, and this is a slide, but it just has like a little squiggly, so it's not really a plan on there. So I had this big plan of kind of talking through history about like how when enslaved people came. Oh, you have the slides. Can you go to the one with the squiggly line, number 15? It says timeline of health inequality. The next one. After that. Yes, thank you. So I had this big plan of talking about like when the enslaved people landed in 1619 and how they were brutalized and experimented on, and then we got to the Plessy versus Ferguson where we were separate but equal, and people had different times where they had to go get healthcare, where there was I know in the African American Museum here they have a sign where it says that Black people could only go to the hospital on Wednesdays to get primary care, and they had to wait in the parking lot instead of in the regular place. So there's all of this kinds of things, but that would have taken too long. So next slide, please. And I wouldn't have done as great a job as this author, Harriet Washington, who basically goes through the medical apartheid. And it's a really good book. It's really long. It's like 400 pages. I haven't finished yet, to be honest. But it talks about different things in historically a troubling tradition where there were the medical experimentations, how people were also continued to be experimented even biomedically in the future, like now, the usual suspects and how they go through all of that, and then brings healthcare, race, and technology together. So it's really well outlined and something to consider reading. Next slide. Next slide, please.
We went on a break.
There they go. So instead of going through all of that history, I figured we could focus more on 3 cases. Has anyone ever heard of J. Marion Sims, the father of gynecology? Okay. So it's very interesting because like his father of gynecology, I was like, oh, I want to be like the diva of family medicine or something like that. So like I really wanted to learn more about him. And in actuality, in the 1800s, he was known for creating a surgical experiment where women had vesico-vaginal fistulas, where the bladder and the vagina had a hole in it, you would leak, it was painful, it was terrible, lots of infections. So he decided to experiment on enslaved women without using anesthesia because he said that Black people don't feel pain. And that's how he created the procedure. And then there was Eb Cade, who was in the Manhattan experiments, which were radiation experiments where he basically got into a car accident, broke some bones. He went to the hospital to get help. And instead of fixing his broken bones, they decided to inject him with plutonium and extract 5 of his teeth to do the studies on how radiation affects the body. And then 5 days later, they fixed his bones and sent him home. And they had a lot of experiment and outcomes of the radiation. But as a side effect, 5 years later, he passed away from heart failure due to the radiation. And then Ralph versus Weinberger was a case where a mother had 2 intellectually disabled daughters. And she wanted to take care of them and give them some birth control because she was taking care of them, didn't want any grandchildren. But she wanted reversible birth control. She wanted to give them the depot injection. Well, what the version was back then, it was in the 70s. And but mom couldn't read. She was illiterate. So she put an X on the form and the doctor explained things to her. And they actually permanently sterilized the daughters without her consent. And they sued and they found out that they had done that to 100,000 people through the government program to sterilize people in disadvantaged populations that they didn't want to procreate. So those are just some examples of why there may be some distrust, especially in the Black community with the healthcare system. And next slide, please. We were trying to figure out how to move forward. So that was this is the 21st century. Is that in the past? Next slide, please. Not so sure. Next slide, please. So now, this is by the CDC. So African Americans are more likely to die at early ages from all causes. I think that's crazy, from all causes. As we can see at the top, with every disease, there's a higher, Black people have more of it and at an earlier age of high blood pressure, diabetes, and strokes. Next slide, please. So this shows a cute little baby. And then if you look to the side, that's 2.3%. So Black babies are 2.3, they have 2.3% times more likely to have infant mortality than white counterparts. Their mothers are 2 times less likely to get prenatal care, and they're 4 times more likely to die from low birth weight complications. Next slide, please. So if you look in the 3rd line down at maternal complications, we see that the Black death rate in mothers or with complications is 77 per 100,000 as opposed to that 3.4. I'm sorry, 22.8. Next slide, please. And maternal mortality, we've seen that it's been happening a lot, especially in the news. We've seen a lot of women passing away. There was a really prominent physician who passed away last year where they did a lot of advocacy for because she was complaining about maternal issues and she still passed away. We see celebrities like Serena Williams, even Beyonce, saying that they had issues and almost died during delivery. So we see that the social economic component does not always make you have a better, higher risk, lower risk of mortality. Next slide, please. HIV AIDS. So while African Americans make up 13% of the population, they account for 43% of HIV-related deaths as of 2018. And if you look into the trans community, Black trans women make up 1 in 2. So 50% of trans women that are Black have HIV. And we know that there are different barriers, socioeconomic wise, like in terms of access to care. If they have, there are programs that help people with HIV get medicines, and we know that people can live long, sustainable, fulfilling lives if they are treated and they have undetectable virus, but there's not always the access to care or the knowledge to care. And there are sometimes some fear of being experimented on, just given the history, especially from the 80s and 90s with the HIV epidemic. Next slide, please. Trans care. So we mentioned earlier about the 1 in 2 Black women, Black trans women who have HIV, but there are a lot of other different disparities on top of the race issues. A lot of them have distrust with just trans people in general having access to care. I've had patients from FQHC I used to work at a long time ago where they would fly to me from other states. I had a man fly to Maryland from Georgia every 6 months because there was no doctor in the area that would treat them, or a patient who refused to get a colonoscopy even though they were of age because they said they would rather die than have the doctors treat them poorly for being trans. Next problem, next case. And we all have heard a lot about COVID, so I won't go into the numbers, but in the beginning of the pandemic, Black people were about 3.2% more likely to die from COVID than their white counterparts. But next slide. There was a study done where it showed 140,000 patients who were seen in person or telemedicine between March and April, and it shows that Black patients were half as likely to come, but then they were also more likely to be diagnosed with diagnosed with COVID at a more severe rate. So they're showing that they probably were going later. Next slide, please. Why? Next slide. So we've all heard about the social determinants of health, and we know that about 80% of our health is outside of the healthcare system. So it's determined by education, job status, income, community engagement, your environment. You're not walking and exercising if your community isn't safe. So we're looking at ways to address that. Next slide, please. This next slide just shows that in a little different way of how they're broken down. Next slide, please. So how does all of that get in some places, but not all? Next slide, please. How many minutes do I have? All right, we're gonna skip this video. Next slide, please. So that video just showed a little, a woman who was socioeconomically disadvantaged and how all of these pieces come together. Like, she didn't have an education, so she wasn't able to get a good job. Her child got sick, she got high medical bills, and she lived in a place where they were kind of redlining and redistributing the vote. So she wasn't able to have people advocate for her, and she was just lost and depressed and sick. So all of that just talks about the political determinants of health. So voting leads to government changes, leads to policy, leads to this, that affects the social determinants of health and health outcomes. So if we are very passionate about creating health equity, we have to be very passionate about putting people in place that will make laws to make it more accessible for everyone. Next slide, please. So how can digital health companies help? Next slide. Let's make a deal. Next slide. Let's make a care deal. So you have to connect with the communities that are being served. We've heard a lot about this, and these are our last two slides for the people to come in, but we've heard a lot about zip codes and how different things are different. So if you're in a digital healthcare company that's building up, and you're in 50 states, like the company that I work for, you have to know that every community is not a monolith. So you have to know what's in that community and what is needed in that zip code. They may need more OBGYNs, they may need more surgeons, they may need different things. And you have to know and connect with this community that's being served. Acknowledge the disparities. Like, don't just go into there and say like, hey, I know you distrust me if you see like a Black patient or something, like with the COVID vaccine or something. Like, ask them why. Acknowledge it. Like, yeah, I know there was experiments, but what concerns do you have and how can I help you? Because it can change some minds. We have to reform the medical funding to increase residency spots. We don't have enough. So when medical school happens, everyone gets into medical school. Well, not everyone, but the people that do, they do all their rotations. They pay a lot of money, but there's a thing called the match where you have to go and you do residency. Everyone doesn't get a spot. I think there are about 7,000 people a year who get out of medical school with no job and they're in debt. So there are different avenues to practice medicine, and you can be a nurse or a nurse practitioner or PA or something. But in order to practice medicine as a physician, you have to do residency. So we have to advocate for the GME and the people in Congress to increase those residency spots so we can have more people taking care of people in these rural and disadvantaged areas. So e-examine for zip code data, we talked about that. Next slide, please. This is the last slide. Deal. So we have to demolish the digital divide. We've seen a lot in COVID with students who don't have computers at home, don't have broadband internet, may not have phones. We think a lot of people have phones. We have to get them access to that. We have to equip patients with user-friendly tools. So you can have all of the information in the world to help them, but if they don't understand it or don't know how to use it, they're not. So a lot of times we use all of this jargon when we're sending care plans or we're telling them how something works. If they don't understand it, they're not going to get that help or they're not going to follow through what they're supposed to do. Assemble leadership teams with diverse lenses, because a lot of times most high-level places are staffed by white men. So we have these lenses and these blinders on it, although we may have allies or people may not have ill intentions. You don't know what you don't know unless you have diverse people in the room to help give you those different perspectives. And then language and literacy has to be put in the forefront, because America's America. Yes, hopefully most speak English, but everyone doesn't, and it may not be their first language, especially when dealing with medical things. So you have to have that access to language and the access to the literacy levels, because on average, the US literacy level is between 3rd and 8th grade. So some of our information is too intense. So next slide, please. I just want to thank you guys for your time, and hopefully we can try to make this healthcare system more equitable by engaging more, voting, especially during these midterm elections, and figuring out ways to advocate for our communities. Thank you.